Hello, Journal Inside viewers. I am Kim Young-taek from National Health Insurance Service Ilsan Hospital. If we try repeatedly placing an implant on the failed site, will the implant eventually survive? Which factors would impact the survival rate? Have you ever thought about this? Many of you must have replaced implants after failure. I did so too. Some of them ended in failure, and some were successful. Then, it made me wonder how much the success rate can ultimately improve if I keep replacing implants on the failed sites. That's the question that got this research off the ground. The paper is titled Evaluation of Failed Implants and Re-implantation at Sites of Previous Dental Implant Failure, Survival Rates, and Risk Factors. Dr. Park Yuson, a periodontist at our hospital, was the first author, and I participated as a corresponding author. By the way, I wasn't the only one who wondered about this. In EAO Congress held in Milan last October, one of the renowned professors of periodontics, Dr. Halm Lei Wang, cited this paper in his presentation. It was such an honor for me. His presentation was also about whether we can place an implant again on the previously failed site. How do you tell your patients about implant survival rate? I usually tell patients that the 5-year survival rate is about 97 or 98%. Even in a perfectly successful case, it hardly reaches 100%. Failed implants will be removed for various reasons. After the removal, we can have the following options: placing on the same site or elsewhere, or not placing at all. Depending on situations, patients can wear partial dentures or make do without the implant. This time, I focused on re-implantation. In particular, re-implantation on the previously failed site. The objective of the research was to check the survival rate when placing implants again on the failed site and identify risk factors affecting failure in re-implantation cases. Let's take a look at selection process of research subjects and methodologies we used. Cases were excluded when re-implantation itself was not possible. Re-implantation position changed, and there was no data to refer to. At our hospital, 2,442 implants were placed on 1,751 patients over the last 15 years. Of them, 91 implants placed on 77 patients failed. For those implants, we analyzed factors. These are factors related with patients, and these are the ones more connected to implants. Other factors are timing of failure and re-implantation and implant spec change. Usually after failure, a larger implant will be placed on the same site. When a smaller one fails, a one-size larger implant can usually be placed. Such cases of implant system change and prosthetic types, etc., were included as a factor. Survival rates were analyzed in Kaplan-Meier curves, and a regression analysis was performed to identify the failure factors. Collated data showed interesting results about re-implantation survival rates and failure factors. Then let's check out more details. Out of 91 failure cases, re-implantation on different sites and no re-implantation cases were excluded, and 69 implants were placed again on the failed sites. Of those 69, 8 failed. And out of the 8, we tried again for 3 cases, all of which succeeded. So the final survival rate was 99.2%. As for the failure reasons, most of them were unspecified, followed by infection, inflammation, and others. On the patient level, age definitely played a role in failure cases. A next factor can be something many didn't expect. Taking antithrombotic agents actually decreased the failure rates. Various analysis was done on the implant level as well, but any of them did not significantly affect the results as a failure factor. Significant factors were put together for multivariate regression analysis, and it turned out that smoking habit and age affected the results most. Through this research, we were able to confirm important factors affecting success and failure of re-implantation cases. Based on the results, I summarized suggestions and clinical takeaways. The research showed that re-implantation was not directly affected by previous failure, and instead of implant characteristics, patient-related factors, such as smoking habit and age, as I mentioned earlier, had more impact. Let me explain more about clinical significance. When we placed an implant on the same site up to 3 times, all succeeded. This is because unless we can adjust the factors affecting the second-time failure, we didn't go ahead with re-implantation. We did sugar control, had patients quit smoking, and did other controls to the patient-related factors. By doing so, we were able to increase the final implant survival rate from 96.3% to a quite high level of 99.2%. I think implant-related factors did not have significant impact in this research since we already made a lot of adjustments. As they are controllable, implant-level factors are less likely to affect the results. In our research, patient-related factors mattered more than implant-related ones. Consideration of a patient's smoking habit and age, etc., will help you minimize failure rate. Implant failure can always happen. It can happen even when you controlled all the factors. But in most cases, if you control factors and keep placing an implant on the same site again and again, the long-term survival rate can be over 99%. I hope you can keep these results in mind and perform 100% successful implant surgery. Thank you for watching.